We have two lectures, personalized versus person-centered approaches. You will see that it sounds so similar, but it's so completely different in its view. We have here on the table, me, myself, as the president of the association, together with the Congress chairs, which is Dr. Karin Schindler, who is working in the Ministry of Health and at the Medical University of Graz, and Professor Bernhard Ludwig here also from Vienna. He's running a big hospital here, and perhaps he will go and introduce the speakers.
Okay. Thank you again. A warm welcome from my side. And I think we just start with the first lecture. I think there will be no questions. It's like a overview. If we have time, maybe one or two. So I would like to ask Professor Ora from Turkey to talk about personalized approaches, please.
Okay. Dear Chairman and dear chairs, actually, dear guests and colleagues, it's a big pleasure to be here, and I'm very honored. And as an outsider, I'm not a researcher working on the obesity part, but I'm in the drug development in general. So, as the first slide, the conflict of interest, I have no potential conflicts so far, since I'm the chair for the IRB at Koç University, the member of Ministry of Health Advisory Board for the clinical trials, and a member of UNESCO International Bioethics Committee, actually. So all my research is funded by public funds, actually. So that's what I mean. So I start with the question where we are in terms of the personalized medicine. So the overview of what is personalized medicine is going to be the first part, and then is there any experimental model to test the personalized medicine, and to what extent, just a minute, personalized treatment is possible, is going to be the third. And I made this little logo here to emphasize the fact that personalized medicine is a big promise, actually. And I think there's a big paradigm shift is going on throughout the medical community and in the drug research. I will just try to entertain with this idea, okay? Oops. So what is personalized medicine, basically? The new disease taxonomy actually changes the diagnosis, but it doesn't make the treatment personal per se. Okay, so this is something that I try to come up with an idea of having a bottom line sentence at the very first moment. Okay, it is a big pleasure to be here in Vienna, because Vienna, I guess, and I believe, like Eric Kandel in his very seminal book, The Age of Insight. I think the scientific medicine was born here in Vienna by virtue of the fact that the symptoms and pathology actually was linked in Vienna by Rokitansky when he was dean, and Škoda, he was the head of the internal medicine. And at that time, the pathologic, microscopic pathology actually came to the reality, and the scientists and artists, actually, like Klimt, they get together in their homes after hours, and they watch histologic slides. Like this inspired very much Klimt also, in this artwork, actually. So the idea of scientific medicine, actually, is the fact that it is evidence-based. It is evidence-based, and we know that the evidence pyramid and the randomized controlled trials are the mainstay of the scientific medicine to assess efficacy and safety, which is very important. And since the second half of the 20th century, the developments in molecular biology and the deciphering of the human genome and patient profiling has changed the whole scope and the understanding of the randomized controlled trials anyway. So in the classical paradigm, which was a little bit of, based on a serendipity, find by screening some molecules with one phase, one drug, one indication scheme as a classical paradigm, one drug for all, basically. We have the disease model, we found disease targets, drugs made, and tested on patients, basically. But with the new era, the targeted therapy changed this, and the diagnosis now is pretty much patient-specific. But when I mean specific, it's not just one-to-one, personal, of course. Nevertheless, in this situation, the patient profiling actually defines the disease, and the disease taxonomy is a little bit changed, and I think it's going to be more and more in the years to come. And we try to have some specific drugs for specific conditions for each drug. The main distinction of this new system is that new evidence gathers in all steps of this clinical trials, so that what we have done is to have many interim analysis and feedbacks over this protocol, so that the protocol is changing constantly. So it is going to be a very dynamic kind of situation. So we obtain success when outcome measures are clear. Like, after the profiling, we reach the treatment. In cancer, it is very straightforward. We identify cancer cells and kill. So that's a very, straightforward kind of situation. Biomarkers play a very important role, and also measurable parameters that are very important. An example, a seminal example is with the BCR-ABL mutation, which results in the leukemia, and when we attack proteins formed by this mutation with imatinib, we obtain a very big breakthrough kind of result in the clinical medicine. But in complex diseases, it's totally a different story. So I took this photo from a park in Istanbul, actually, and this is the metabolic syndrome monument, by the way, and it seems that the surgeon god actually kills the metabolic syndrome, like all surgery does actually. Here the problem is the fact that in complex diseases you don't know by drug terms how to attack. So the artist apparently, inspired from the De Fronzo's paper, in 2009 paper, showing that the main ingredients of hyperglycemia named as the ominous octet, and this ominous octet being a monster, actually. Okay. In complex diseases, the modeling is a problem, like metabolic syndrome, obesity, type 2 diabetes, but also in hypertension and in many other complex diseases. And they are all multifactorial, complex, and difficult to attack. So what we do actually is, we have now a big tool named as Genome-Wide association studies. We detect SNPs and copy number variations, indels, and so forth and so on, all kind of small mutations, and try to associate with this to different phenotypes, like fast and slow responders and acute reactions, and try to cluster off-target responses with adverse effects and lack of efficacy. So this is a straightforward kind of paradigm that we use all the way for the drug development. But let's give this example of an obesity example. The FTO gene variant, we know that there are many copy number variations, and these people are obesity prone, and many studies show very clearly that they show a preference for high energy foods and hyperphagia. Unfortunately, in a new paper, from almost 8 years after Frayling paper in Science, Livingstone et al. In obesity reviews show that it's very difficult to prove in large studies the assumption that they made in their initial paper by saying that they have preference for high energy foods. So this is a very important thing that we should keep in mind for all complex type studies, and I will just develop and evolve over this idea. It's not easy to put the causality here, okay? Why? Because there are many flaws in the clinical trial design, like, reporting the dietary intake for each and individual patient. And the other thing is, lifestyle changes also the course of the disease. So this is also something that we are, struggling to deal with. Another example with Prader-Willi syndrome, it's a complex genetic disease. We know the genetics very clearly. It's a uniparental disomy of the chromosome 15. And we have also a very accurate, almost 99% accurate diagnostic test. And we also have clinical experience with many phenotypes, with very rich clinical features, and many clinical outcomes. So those clinical outcomes also not easy to discuss. The sole approved treatment is the growth hormone therapy, and unfortunately no successful treatment for hyperphagia. Hunger is a difficult signal for analysis here, and there is no biomarker to measure for the hunger actually, and different phenotypes were pooled. And social support and quality of medical care also changes the outcome, and it's a very rare disease, so the number to reach to attain significance is not easy. So when I check the trials that involve eating in clinicaltrials.gov, I just focused on phase 3 because this is the critical time when all industry and academics think about the commercializing the drug product. Out of the 298 studies that involve the eating behavior, hyperphagia type of eating behavior abnormalities, only 33 reaches the phase 3, and now currently there are 10 are active. And if you look at the drugs, dasotrelin, diazoxide, intranasal oxytocin, and liraglutide, only 2, diazoxide and oxytocin, are being tried on the Prader-Willi syndrome. And if you look at the terminated ones, there are many of them that are not even reached to the end of the trial for obvious reasons that I don't have time to discuss now here, but we may discuss later on. And none of them for Prader-Willi syndrome. So it's very difficult to do clinical research in that terms, actually. So the path to personalized medicine, I think, to sum up, we need the new smart trial designs like basket or umbrella trials or N-of-1 trials. This needs to be very dynamic, and frequent interim analysis are key. Genetic variability must be considered, different ethnic groups. Small numbers are no good for the genome-wide association analysis as well. The consent becomes a very important issue. There's a big discussion within the medical community as well as in bioethicists, blanket versus specific consent, and with this new personal data rules and laws, it's getting to be very difficult. The other thing is the genetic data is not included in personal health records. It's considered as a personal information, which is not health information, because even when planes crash, we identify the identities with the DNA, so DNA cannot be anonymized in that sense. Okay, and we need to engage also patients in clinical trial community. I just will mention a little bit later. So the lessons learned, retrospective analysis by taking genome data into account is a crucial thing, but this is possible if the samples were collected beforehand. So you need to have a consent to do this. And the consent may not be so easy to get because we don't know what our research will lead us in the future. The analysis of adverse effects may benefit from such opportunities, and drug repurposing in that matter is a very important thing. And difficult to meet the expectations of the patient's families. The consent taking, as I said, is a big problem, and the cooperation with mentally challenged patients is difficult. The other, the thing that I want to point out here is that the low genomic literacy is a risk factor, as Nakamura et al., I think, brilliantly showed in hypertension and obesity studies. And it's not easy to improve the level of knowledge with this complexity of the genome literacy, basically, especially in the patient groups. And funds are limited because drug companies don't like small groups to get the results. And the support for basic research is very critical, is obviously, okay? So obesity is a very hot research area. And if you look at the experimental models, you see, when we get to know the DNA, if the gene is unknown, we put it in a mapping unit and we start cell biology experiments together with animal experiments and biology of disease and biomarker identification. I think this one is going to be, the whole circle is very important to reach the new drug targets and new therapy modalities. And in the end, this translational medicine clinical trials relationship also is very critical. And if you look at the experimental models, as we go to the in vitro studies, the throughput is very big, actually, owing to the molecular biology and cell culture experiments, and the cost is quite acceptable. But as we go up to the ladder to in vivo studies, and starting from zebrafish to non-human primates, the relevance is getting increased. Nevertheless, the cost is very big a problem too. And in biotech terms, a major breakthrough has been happened in every 10 years. We started with the 1980s with transgenic techniques. Leptin knockout mice was very big issue at that time. But today, in 2010, we have the gene editing with a CRISPR-Cas system. Gives us a very wide application areas. And just recently, in 2018, there's a leptin and leptin receptor gene editing paper from a group from Korea, which also allows us to tell you about reverse genetics rather than the forward genetics. I think this is going to be a big breakthrough in the years to come in complex diseases. So how feasible is it? So if you look at today's situation, the individual is in the beginning, at the center here, and there's a huge accumulation of big data, which makes the individual as transparent as can be over the years. Nevertheless, the whole system that contains the data actually is getting more and more opaque and not so transparent actually. So there's a big concern in many ways to manage this big data, which is very important for the hypothesis forming. And those hypothesis testing may yield to several different molecules that may be termed as personalized medicine. But the personalized medicine here is not the personalized medicine as we think of a tailor-made suit, actually. This is pretty much clusters of groups. And these cluster groups, some of them could be much more advantageous than some others, actually, in terms of the medical treatment and the outcome. This is also something that we should think about in the future, because the value here depends on the patient outcome versus cost, and it's obviously that there's a limitation factor in that the cost should not exceed to a certain limit in order to be applicable to any person in a system, actually, within the countries and in the global scale as well, okay? So if you see the big picture now with the risks and benefits, I told you that the 4 Ps of the personalized medicine is the personal, preventive, predictive, and participatory. And if you look at the preventive, predictive, participatory part, this gives you too much responsibility for an individual. What I mean for that, it could become too obstructive. For instance, if you get the whole authority about your genome, actually, then people may say that, okay, you have the risk to become obese, then if you become obese, it's your fault kind of situation, okay? And this may have, signal an emergence of an authoritarian medicine like your gene is your fate and your fate is sealed. And it's pretty much like that. And data repositories actually contain very highly sensitive data, and the different stakeholders may have a very different point of view about these repositories, like insurance companies, drug companies, and governments, and individuals as well. So another important issue is the left behind populations, because we don't have the ability, we will not have, at least in the midterm, a possibility to address to all kind of people. So it's going to be subsets of people that are more advantageous than the others, and the left behind populations could be a big problem. And I also think, as a cautious physician, applications of a new technology may have unexpected outcomes, and social impact needs to be discussed. On the other hand, there's a very important positive side, which enables also the patient to seize its fate, because it knows through the DNA-based technologies what he needs to do, actually, and some other people may also benefit from that fact either. So the question is, how fast shall we adopt personalized medicine? From an individual context, it's the beneficence, justice, and autonomy is the main tenets of the bioethics, basically. And from the social context, the political decisions, equitability, and affordability are important, ideas. Unfortunately, or far fortunately, because humans are social animals, social context sets the ground rules. So this may have a very disparate kind of applications and management in different parts of the world initially. But I think the world needs to discuss these all together. I finish my talk by just putting this question, which precedes which. We have the science which really works for the beneficence of the humanity, and also, the most importantly, for the veracity, because the real world, the reality actually is determined by the science. So even if we don't like the end, if you become pretty much sick or whatever, bioethics, on the other hand, deal with the equity, justice, and autonomy. And sometimes, in order to have autonomy, you need to have the full veracity, actually. So if you don't know anything, you cannot have an autonomous kind of decision, actually. Too much emphasis, on the other hand, on genetics may put social determinants of health in peril and redefines patient-physician relationship. And I think we need more and more public deliberations, and the debate on personalized medicine should not be limited to expert panels, actually. And for these, I really thank for your attention, and with my campus in overlooking Bradstreet.
Thank you very much for this very interesting talk. Again, we have no discussion for the sake of time, and I will hand over to Karin Schindler. Thank you.
Thank you. And now we move from personalized to person-centered. And I'm very happy to announce Professor Rachel Betterham from UK to give this talk. Rachel, the floor is yours, please.
Good afternoon or good evening, everybody. I'd like to thank the organising committee for inviting me, and I'd like to thank you all for being here. Now, I'd like a show of hands at the beginning as to who actually knows what person-centered care or person-centered approaches are. Because I have to confess that until I started writing this talk, I don't think I was entirely clear. So who actually has a very clear idea in their head what person-centered care is? So hopefully, by the end, a few more people might know. So here are my disclosures. So over the next 20-25 minutes, I'm going to talk to you about what is person-centered care, why is it important, what it actually involves if we're going to implement it, and then focus on person-centered care for people with overweight and obesity. because that's the thing that we really need to be doing. So what is person-centred care? Well, it is what it says on the tin, but there isn't a precise definition. There's lots of different definitions, but it's basically putting people and families at the centre of the decisions that affect their care and making sure that they're working in partnership with healthcare professionals. So it's changing the sort of the focus of a consultation from what's the matter with you to what matters to you. So it's all about what actually matters to the person that you're seeing, and it shifts it from a disease focus to an actual person focus. So it really is about thinking from the patient and the person's perspective and treating them with respect and dignity. And it's also sometimes called patient-centred, family-centred, user-centred, and individualised. So the word person is used to really make it holistic and not to focus it down just on one disease. So we'll often say, oh, the diabetic patient. Well, actually, we need to think about all the other aspects of that person, not just one disease process. And it also, the person aspect takes into account their preferences, their well-being, and also their social and cultural background. So a person-centred care is really about doing things with people rather than to them, which is a real sort of paradigm shift from how medicine was sort of traditionally practiced. And it really is rooted in sort of the universally held principles which are enshrined in international law. As I'm going through these, think about whether your patients with overweight and obesity are afforded these privileges. So human right and dignity, non-discrimination, participation and empowerment, access and equity, partnership of equals. So person-centred care really is about working in partnership. It's not about just giving people what they come in and ask for. It's not about, oh, I want this, oh, yes. That's not sort of working in person-centred care. It's about providing them with the right information and about involving them in every aspect of the care and the services. So planning, developing, monitoring, and ensuring that the care is actually fit for what they want, so that it's fit for their purpose. So why? Why do we need to change from the doctor-dominated, this is what's best for you approach, to a person-centred approach? Well, it's to do with how disease has changed. So we've gone from infectious diseases being the main burden to being chronic diseases. And not only that, but most patients will have more than one chronic disease. So people are living longer and they've got multiple problems. So it's not just short bouts of care that they need, it's lifelong care. So professional care that a patient will probably have during a year is about 5 hours, if they're lucky, coming to a diabetes clinic or for their COPD. And that means that for the other 8,755 hours of the year, they're actually managing their conditions themselves. So we really need to empower people to manage their health, apart from the 5 hours that they might have seeing a physician. So we really need to shift the balance away from health services that are disease-focused and doctor-focused and more patient-focused. And what's the bigger picture? Well, as you probably all know, the bigger picture is actually universal healthcare for all. And that's one of the key targets of the WHO. And if we're going to do that, then again, we really need to shift how we're delivering care, because we don't have the resources for it to be doctor-focused. It has to be person-focused. And we need to deliver it through an integrated and people-centred lens. Otherwise, we're not going to reach the people who actually won't access healthcare. So it really does need to be designed for people in the right format. So why not patient-centred? Patient-centred, again, is good for people who have diseases. So it's about a holistic approach to health. But we don't want just to treat people who have diseases. We want to encourage health and well-being. So we need prevention. And in order to have prevention, we need to reach people before they're unwell. So in order to do that, it needs to be reaching out to families and people who are well beyond the clinical setting and empowering change to improve their health. So by having a person or a people-centered approach, it means that we're going to get a much better overall improvement in global health. And to do that, we need to educate and empower people to be involved in protecting their own health. So there's a real focus with person-centered approach on health and well-being rather than disease. And this diagram here is the determinants of health. And we have to remember that health is a complex interplay between physical, social, economic, cultural, and environmental factors. And again, so we need a whole systems approach when we're thinking about person-centered health rather than just focusing on the medical aspects of it. So there are many different aspects of person-centered care, and these are just a few of them. But being able to access the appropriate care is absolutely key. And again, think about your patients with overweight and obesity, being able to access care that's appropriate when they need it. We also need to ensure that care and services are joined up, not sort of separated by voids that don't talk to each other. And there needs to be excellent communication about health and information and education to the general population and also to specific disease groups. But then we also need to make sure that the physical environment is suitable for people. Is it safe for them? Is it appropriately sized? Are they comfortable? And we also need to not forget the emotional support that people need to have in addition to just medical support. And we need to involve their family and friends. People don't come in isolation. They live in an environment, and in particular, when we're thinking about overweight and obesity, we really need to think about their family and friends and who they're living with. And also, it changes. So one person's needs are not the same as another. And also, they change with time. So person-centered care needs to be individualized, personalized based on genetics as we go forward, but it also needs to be able to change as their life changes, so it needs to be responsive. So why is it important? Why is person-centered care the latest sort of buzzword? Well, it's all about improving healthcare delivery and improving global health. And the concept is that if we actually give people the power, then it will actually improve quality. And if we put people at the center of their care, then they will be the people who will really be responsible for driving quality, because they are the people who are living this care, not just delivering it. And hopefully it will mean that people get the care they need. They'll be more active in looking after themselves because they're invested in the care systems. And one of the ultimate aims is actually to reduce the pressure on the health and social services. And there is quite a lot of research looking at the fact that this approach does really reduce how much people use healthcare services. People to live a healthier lifestyle, encourages exercise and healthy eating, and also encourages people to be really involved in decisions rather than just being passive and doing what they're told to do. And there's an impact on health outcomes already been proven using this approach, for example, a decrease in blood pressure. And as I've said already, there's evidence that this approach reduces how much people use healthcare services because they can manage their own problems without actually going along and using services. And from the professional perspective, because doctors also like to have some positivity back from their patients, there's again evidence to say that this approach actually, doctors enjoy it more because their patients are also more confident and engaged in the whole disease management process. So I'm British. We fortunately have the National Health Service, which this year celebrates its 70th birthday on the 4th of July. And actually, patient-centred care is one of the 7 core principles of the NHS Constitution. And in theory, strengthening the patient voice is also part of the NHS policy, with a move away from the sort of paternalistic approach where healthcare professionals do things to patients to actually being patient-centred. So the Health Foundation, which again is based in the UK, has 4 principles to person-centred health. But round the outside of this is that the person must be treated with dignity, compassion, and respect. So care has to be enabling. What does enabling mean? Well, it means that if you're going to have care that's enabling, you have to have a true partnership between the healthcare professional and the person receiving the care. It can't be a doctor-dominated system. Care has to be coordinated, and it also has to be relevant to the person, so it needs to be personalised. So the WHO, in order to achieve its vision of universal healthcare for all, published a framework for integrated people-centred health services in 2016. So the vision for this is that all people will have equal access to quality health services. And I think that's a vision that we should all sign up for. That the health services that people are going to receive are co-produced in a way that actually meets their life course, which your needs change as you age. But it also needs to respect their preferences, because people are very different. And they need to be coordinated, comprehensive, but obviously safe, effective, timely, efficient, and acceptable. So it's all sounding good so far. So in order to do this, they came up with 5 interwoven implementation strategies, which are illustrated here. So you obviously need to engage and empower people, because unless you've actually got people interested and give them the knowledge they need, then you're going to get nowhere. So engaging in empowerment is critical. Then you do need a strong governance and accountability, otherwise you get people doing things that are unregulated. And then we need to reorientate the model of care away from the doctor-dominated, you do this and come back approach, to this is the services that we need, and empowering people to look after their own health. Coordination, again, is absolutely critical, and creating an enabling environment. So this slide here just sort of illustrates conventional care compared to a people-centred care approach. So with conventional care, the focus is on illness and cure, whereas with a people-centred approach, it's on health needs. And there's a very different kind of relationship, whereas conventional care is often very episodic, delivered with acute episodes, whereas people-centred care is an ongoing approach. With conventional care, users are the consumers, whereas with a people-centred approach, then the people are the partners who are managing their own health most of the time in the community that they live in. So there are 5 domains of person-centred care that you need, but critical to all of it is information and education. So unless people understand, then they can't get involved in the rest of the processes. So information and education are critical, but that information and education has to be communicated in the right medium, at the right level, so that people can actually digest it and understand it. Then people need to be involved in decisions. Care needs to be coordinated. And then for people with diseases, there needs to be an active care plan that can then be enacted and followed. So again, there's a public body called National Voices, and this is a quote from their website about person-centred care. And again, from the person's perspective, it means that they can plan their care with people who actually understand them, understand their environment, and really feel that they're in control of their own care and their healthcare problems. One of the biggest problems at the moment is healthcare records. And I have no doubt that as we have improvements in information technology, then this will really also help person-centred care. I'm not quite sure what it's like in all countries, but in the UK, we have a fragmented healthcare system with lots of different electronic healthcare records that don't talk to each other. So a patient will often have multiple sets of records in multiple hospitals, and this is a real problem when you have people with multiple chronic diseases and complex patients, because it often take you hours to try and piece together what investigations have been done when, and we always go back and start taking the history again. So in an ideal world, we'd have a centralized health record that everybody put the data into, and that would be fine. But the practicalities of doing that using the current data are a problem. So blockchain. Blockchain may have the solution here. So blockchain you may have heard of to do with Bitcoin. So blockchain is going to be sort of the new internet, and it probably actually does potentially hold a lot of benefits for healthcare. And if you have a spare 10, 15 minutes, I urge you to go into YouTube and have a look at blockchain and how that's going to impact upon healthcare. The advantage of blockchain is it's decentralized and also much safer in the way that it's encrypted. So potentially what that would enable to happen is actually for everybody involved in a person-centered care to enter electronic data that everybody else can access. So we need to be mindful of technological advances because they will impact upon person-centered solution. With anything that we do in healthcare, we need to assess it and then improve on it based on the assessment. So traditional healthcare is measured looking at activity, clinical outcomes, and sort of not really focusing particularly on people. Whereas person-centered care really does focus on people, on their sense of well-being, quality of life, but it also does need to look at disease outcomes. So we need to have both in person-centered care. We need that health-related quality of life, but we also need to see what we're doing in terms of impact upon disease. So some of the outcomes, which I'm sure you will have heard of, so health literacy is really important, patient-reported outcome measures or PROMs, something called PAM, which is a patient-activated measure, which is 13 questions which really assess a person's concept of themselves as an active manager of their health and healthcare. So I think PAMs are going to become more prevalent. There's also health education questionnaires, PREMs, and also qualitative approaches, interviews, and narratives. So we need different sorts of measures to really see how we're impacting using a person-centered healthcare approach. So what about person-centered healthcare for people with overweight and obesity? So obesity, overweight, chronic condition, disease, linked to multiple other long-term conditions and reduced life expectancy. So based on everything that I've told you already, you would anticipate that actually this would be an area where person-centered care was already being implemented. Well, is it because obesity is a relatively new, inverted commas, disease? Well, actually, I wanted to give you a little bit of history. So Hippocrates, 2,000 years ago, first recognized that obesity was a disease, that those who are constitutionally very fat are more apt to die quickly than those who are thin. And if we look at the Hippocratic corpus, obesity was considered the cause of disease and in extreme death. Well, what if we go more recently? So 1997, the WHO published their first document on preventing and managing the global epidemic of obesity. And in this, they clearly stated that obesity was a disease, a complex, incompletely understood, serious chronic disease that required prevention and management strategies at both the individual and societal level. So again, clearly showing that this would benefit from a person-centered approach. As we know, more than half the global population are now overweight or obese. So again, we've got a serious condition that's very prevalent. Not only that, not only is it affecting adults, we have a serious condition that's prevalent that is actually now really affecting our children, with 41 million children under the age of 5 overweight or obese. And if we look at the rates of obesity, they're increasing exponentially. So again, we've got a serious problem here that would benefit from a family-centered approach, not just a person-centered approach. We also know, as I've said already, that obesity reduces life expectancy. So in terms of the fact that person-centered approaches are really meant to help you when people have got lots of other long-term conditions, if we look at all the diseases that come with obesity, as you know, there are multiple metabolic problems, in particular type 2 diabetes, fatty liver, infertility. There are the mechanical problems of obesity, and there are also the psychological problems. So again, all of these, if you were using a person-centered approach, would really benefit from this topic or manner of management. So do we do this in the UK? So telling you that the NHS has got person-centered approach as one of its 7 core values. We certainly have a large problem with overweight and obesity in the UK. We have 27% of our adults are obese, and the other 36% are overweight. And this weekend, they published in our newspapers that our obesity rates in 11-year-old children have now overtaken America. We have 1 in 5 11-year-old children with obesity compared to 18% in the US. So again, we've got a big problem, but are we using it? So NICE published very comprehensive guidelines in 2014 on the identification, assessment, management of overweight and obesity in children, young people and adults. And this again states that we should be using a person-centered approach to manage people with overweight and obesity. We also have this fantastic tier system, which starts off at the bottom with tier 1, which are public interventions. Then we have multi-component weight management, multidisciplinary teams, and then bariatric surgery. So this is what is supposed to be in place. Excellent guidance, excellent theory of what should be happening. And I do really want to highlight the bariatric surgery because we have a lot of evidence for bariatric surgery. So we know that bariatric surgery for people with severe obesity engenders marked, sustained weight loss for 20 years. We know that it causes marked benefits in terms of the comorbidities that come with severe obesity. In particular, type 2 diabetes goes into remission or is markedly improved. Improved quality of life also prevents lots of other problems with an overall decrease in mortality. So bariatric surgery is a really effective treatment for people with severe obesity, and it also decreases the microvascular complications of type 2 diabetes by 30%. Again, we have fantastic, nice guidance saying that we should be using bariatric surgery for people with obesity and type 2 diabetes. There's then international guidelines, again, stating that this is what we should be doing, and Diabetes UK also say surgery must be used. When we look at what happens, less than 1% of people who are eligible for surgery actually have it. So despite all of our best guidance, our concept of person-centered care, we actually have not at all been delivering on what I've been telling you about. We have poor training of healthcare professionals, lack of a patient voice, poor provision of specialist clinics, poor access to long-term treatment. So recently, an all-party parliamentary group, so this is all the different parties, have looked at what's going on in the UK in terms of the provision of obesity services. And this was published on the 15th of May of this year, looking at what is the current landscape in the UK despite all of our guidance. And it was actually very insightful. So out of the people surveyed, so this was a combination of people with overweight and obesity and healthcare professionals, 88% of people with obesity said that they'd been exposed to stigma and criticised as a direct result of their obesity. 94% of the respondents said that there wasn't enough evidence or not enough knowledge about obesity amongst the public, politicians, and other stakeholders. And only 26% of people said that they'd been treated with dignity and respect. So this is a fundamental sort of core value that, and 74% are not actually feeling that they're being treated with dignity and respect. And more scary, given that in the UK, the first point of call is your GP, 42% of people said that they felt too uncomfortable to even speak to their GP about their obesity. Is this just a UK thing? No. So the Awareness, Care and Treatment in Obesity Management Action Study, which was undertaken in the USA, to look at sort of barriers to obesity management and to look at sort of behaviour and insights, also found a very similar problem. So again, if you actually ask people with obesity, 82% of the people who were actually asked considered that the weight was just their own problem and that they couldn't ask anybody else for it. And only 55% had had any formal diagnosis from their healthcare professional. And again, if we go to healthcare professionals, they're not much better either. So obesity, which is a chronic condition that we know has serious complications, then actually how it's being managed in a person-centered approach, then it really isn't. Why? Well, weight bias, stigma, and discrimination are the key three problems that we face if we're ever going to be able to implement a person-centered approach to people with overweight and obesity. So weight bias, which is negative attitudes and views about obesity and people with obesity, which is really propagated by the media. Weight stigma with labeling, stereotyping, damaging identity, really is deeply rooted in society. And then weight-based discrimination with verbal, physical, and subtle and overt actions and expressions, often coming from even healthcare professionals. Again, this is recognised by the WHO that obesity stigma has really adverse health problems and causes health inequalities. And that obesity stigma is a fundamental cause of health inequalities and adds an added burden to the people who are already affected beyond the impairments that they already have. So what are the consequences of obesity stigma? So that there are the individual consequences to the person, but there are also the much bigger public health consequences with a disregard of sort of efforts for obesity prevention and further increase in health disparities and social inequalities. So all of this, the weight, stigma and discrimination at a population level is causing increased morbidity and mortality. So within the UK, I did a programme last year and there was very evident discrimination against people with obesity throughout the NHS, which is something that was really quite shocking. So how do we get around this? We need a public-centred, public health approach. We need to consider the complexity of obesity and the people's lived experiences. But most importantly, we need to support people affected by overweight and obesity and give them a voice so that they actually can speak and give that voice to politicians. We need to empower people to ask for the care that they need. And this is happening. So ECO Council is very powerful in helping people with overweight and obesity. Within the UK, we have patient groups, but these groups need to be supported and empowered for them to have a voice. Otherwise, they do get attacked by the media. So we really do need to reduce weight bias and obesity stigma if we are going to do anything to improve the care of the people that we look after with overweight and obesity. We really need to recognise it as a public health and society issue. And we, as healthcare professionals, really need to take up the mantle here and really take on the media and our politicians and really make sure that we make a difference to stop weight bias and discrimination. And we need policies to prevent stigma. And we need education, education and action rather than just doing nothing and coming and nothing changing. So we do need to work with the media. We need positive messages from our newspapers and from programmes. But having gone through my beginning of my talk about the benefits of a person-centred approach, I think we really do need to be adopting a person-centred approach for people with overweight and obesity in terms of prevention, treatment. But in order to do that, we really do need to tackle the weight bias, stigma and discrimination. And the people who are going to do that are the people in this room. So it's a bit of a call to action. Thank you for your attention.
Thank you so much also for reminding us for a person-centered approach and the call for action.